Dr. Wu, at the Retina World Congress meeting, you discussed how to use combination therapy for RVO effectively. Can you sort of outline your presentation and what you talked about?
Sure. So nowadays, primary treatment for CRVO is based on intravitreal monotherapy of anti-VEGF agent or intravitreal corticosteroids. However, despite the benefits of that therapy, there's still many eyes that require many injections, and some eyes do not respond. And when we get those eyes that do not respond, or we try to lessen the burden of injections, we might want to consider combination therapy. The combination therapy would involve any of the different modalities, such as combining steroids plus anti-VEGFs, or even including laser or even vitrectomy. I'm going to talk mostly on the role of the intravitreal anti-VEGF and the steroids. And the problem with that is that the literature is very short on studies. Most of these are retrospective case series, so they don't really give us that much information. There was this study that compared intravitreal bevacizumab plus triamcinolone versus intravitreal bevacizumab. And the results of that with regards to visual acuity, number of injections, and the retreatment rate were pretty much identical. There was another study that looked at combining anti-VEGF plus the dexamethasone implant, and they showed interesting data. However, they did not compare it to monotherapy, so we really don't know. Another avenue that people have explored is looking at the areas of non-perfusion in the retina and doing some laser to those areas, thinking that perhaps those areas of non-perfusion are the ones that are responsible for the increased VEGF load in these eyes. The studies have been sort of equivocal. There are several studies that have shown that there is no role for the laser, the targeted laser to these areas. The problem with the studies is that they probably started doing the laser too late. There are a couple smaller studies that have shown that maybe if you start soon enough, there might be some benefit to that. So in the end, there is not much in the literature that can guide you in terms of combination therapy. But in cases where you see recalcitrant macular edema, it's something to think about.
So, in the bottom line for the retina specialist who's treating such patients, what's the take-home message for them?
So I would consider combining agents sooner rather than later if you're going to think about doing combination therapy. And if you want to do the laser, you really need like wide angle angiograms to really detect the areas of non-perfusion to do the targeted laser.